Good morning. Today the lecture topic is on periodontitis. From this class, we would like you to know the etiological features for chronic periodontitis, list at least three microorganisms associated with chronic periodontitis, describe the clinical features and the radiographic features of chronic periodontitis, and justify the treatment plan for chronic periodontitis. For the aggressive periodontitis, we would like you to know what is the classification based on the AAP classification, explain the microbiological etiology, summarize the clinical and radiographic features, and categorize the treatment modalities based on patient needs. So to start with, periodontitis. This is defined as an inflammatory disease of the supporting tissues of teeth caused by specific microorganisms or groups of specific microorganisms, resulting in progressive destruction of the periodontal ligament and alveolar bone with increasing probing depth, recession, or both. So the catching word here is your increasing probing depth, recession, and another catchy word is your clinical attachment loss. So we will deal about it in the later slides. Infectious diseases resulting in inflammation within the supporting tissues of the teeth with progressive attachment loss and bone loss is your periodontitis. So now coming on to the various classifications which were given for periodontitis. Initially in 1989 it was the AAP classification in 1989 with such a list of classifications, and next in 1993 it was again further decreased into three classification. But in 1999, the perfect classification was given, wherein the person with chronic periodontitis had these following characteristics. So it is prevalent among adults but less among the children. Amount of destruction is consistent with the local factors. It is associated with a variable microbial pattern. Subgingival calculus are frequently found. Slow to moderate rate of progression of bone loss is there, with possible periods of rapid progression. Possibly it is associated with other conditions such as systemic disease such as diabetes mellitus or HIV infection. If there is local factors, it could lead to periodontitis. Environmental factors such as cigarette smoking and emotional stress were also associated with it. Or it could modify the disease. So chronic periodontitis has been further classified into localized or generalized based on how much amount of teeth is being involved, and it has been further classified or characterized as mild, moderate, and severe based on the clinical attachment loss. So localized is classified as less than 30% of the teeth involved, and generalized is classified as more than 30% of the teeth is involved. Mild, 1 to 2 mm of clinical attachment loss present. Moderate, 3 to 4 mm of clinical attachment loss present. Severe, more than 5 mm of clinical attachment loss. So coming on to the stages of periodontitis. So initially the staging starts with your gingivitis. But if the gingival inflammation is not controlled, then it leads to the next stage, that is your periodontitis. So here there will be diseases which progress in bursts of activity of unknown duration if untreated, and it can exist in active and inactive states. So there are going to be two stages in it. It could be a stage of activeness wherein there is active bone loss involved, or it could be a quite inactive period where there is no bone loss at all. So chronic periodontitis is not a continuous disease process, but like the other infectious or the inflammatory disease. So you have periods of activity and periods of inactivity as well. So chronic periodontitis has such a lot of microorganisms involved in it. So initially you will have the green, yellow, violet, and the blue species which are involved. So if these three species are there, they are somewhere in the lower level of infectivity. But when it goes to the orange and the red species, as the color denotes, it means that the severity of the infection has increased. And if you find the red complex organisms, mainly your Porphyromonas gingivalis, Tenora forsythia, and Treponema denticola, it means that the ultimate form of disease has started, or periodontitis has started. So these are the other microorganisms, and this pyramid shows that the microorganisms which are of low infectivity are present in the lower grade of the pyramid, and the microorganisms which are of the highest infectivity are present at the tip of the pyramid. That is your Porphyromonas gingivalis, Tenora forsythia, and Treponema denticola, collectively known as the red. So local factors I mean, there are certain risk factors for the periodontitis when it occurs. So, first and foremost is your local factors. So, what are the local factors? Of course, it's going to be your dental plaque, which is going to accumulate on the tooth and the gingival surfaces. Next is the red complex microorganisms, which I told you. Please pay attention to them and please know all these three microorganisms. It's important. Tenella forsythia, formerly known as Bacteroid forsythus, Porphyromonas gingivalis, formerly known as Bacteria gingivalis, and Treponema denticola. So we remember it as PT square, that is Porphyromonas gingivalis, Tenella forsythia, and Treponema denticola. So these three microorganisms, if it is found in the oral cavity, then definitely that patient is going to be a risky patient for periodontitis. The other risk factors are your plaque retentive factors such as your calculus or the subgingival or the overhanging margins of restoration, caries lesion which is going subgingivally. The second is your systemic factors. So not only that local factors cause a problem or it is a risk for periodontitis, but systemic factors such as diabetes increases the severity and the extent of periodontal diseases. So in fact, it has been told that periodontitis is considered to be the sixth complication of diabetes. So almost all the patients with diabetes would have some form of periodontal activity going on if they are not going to maintain a proper oral hygiene. So apart from this, you have the environmental and the behavioral factors such as smoking and emotional stress. So this could add to periodontitis as well. Genetic factor is always a possibility in any kind of periodontal diseases. So you can see how the pocket is being formed. So you already know that if the gingival sulcus is extended, then it is called as the periodontal pocket. But then if it goes very much beyond, and if it's going to be beyond our level of taking the calculus or the plaque, then it results in the real pocket formation, resulting in periodontitis. So what are the clinical features? The main clinical features include, so coming on to the clinical features, probing depth measurement alone is inadequate. So which means that if I tell it is going to be 4 mm of pocket depth, so that alone will not tell that the patient is having periodontitis. For this, there should be an additional clinical attachment loss as well. So the measurement of the clinical attachment around a tooth provides insights on history and extent of periodontal destruction around the tooth. One common pitfall of clinical periodontal examination is a direct translation of periodontal probing depths as clinical attachment levels when the gingival margin lies above the cemento-enamel junction, leading to an overestimation of attachment levels. So, how do you diagnose periodontitis, or how do you diagnose periodontal health? So coming on to the diagnosis, it can be diagnosed with the help of a periodontal probe or through radiographs, that is with the help of the bone morphology. Radiographs such as bite wing, IOPA and OPG can be taken. So IOPA is generally the full radiographic IOPA contains 14 intraoral fins and 4 posterior bite wing films. So with this, we will be able to find out what recession is and what probing depths are. So you can see 3 different diagrams here. All this has the same probing depth of 4 mm, 4 mm and 4 mm. But then can you see that the junction epithelium has shifted below in each of this? In case of the diagram A, the junction epithelium is near the CEJ. Whereas in case of diagram B, the junction epithelium is below the CEJ. Whereas in case of diagram C, the junction epithelium is far below the CEJ with gingival recession as well. So out of this, though they are having the 4 mm probing depth as equal for all the 3, the amount of destruction in C is comparatively very much higher than A, which means that A is generally not a case of periodontitis, but C is definitely a case of periodontitis. So this is how clinical attachment loss plays a level. Clinical attachment loss is calculated from the CEJ to your to the bottom of the pocket. So based on that, diagram A tells that there is no clinical attachment loss itself because the bottom of the probing pocket depth and CEJ are at the same level. Whereas diagram C, you can see the difference between the CEJ and the bottom of the probing pocket depth. So that is a clear-cut case of periodontitis. Next, there are different pocket depths with the same amount of attachment loss. So same as the previous case. So you can see the amount of attachment loss which is present in case of the A diagram, B diagram and C diagram. So eventually there is gingival recession as well. Next, you can see the clinical image. As I told you, a set of 14 x-rays will be taken, IOPAs, along with 4 posterior bite wings constitutes the total OPG image, and you can see the bone loss in each of these radiographs. I'm not able to show you with the exact location how it is, but then we will again discuss it in the classroom forum for easy understanding. So eventually, once you take the probing depths, once you take the clinical attachment loss and the gingival margin or the gingival recession, you will have to plot something on its side. This is called as your periodontal charting. So you plot on each measurement of the teeth you have taken on this periodontal charting, and this periodontal charting gives you the mean attachment level, which is present in the middle. You can see 4 readings in the middle: mean probing depth, mean attachment loss, plaque percentage and the bleeding on probing percentage. So based on this mean attachment level, you will be able to tell what is the severity of your periodontitis. So here there's a link for your periodontal online charting. So once you go and click this link, you will have an image like this. So you can enter your gingival margin, that is your gingival recession, as well as your probing depth value. Once you enter them, then the charting itself will give you how much amount of attachment loss is present. So next, coming on to the aggressive periodontitis. Aggressive periodontitis is a little different from your chronic periodontitis. So the following characteristics are common with all the aggressive periodontitis patients. So such a patient would be a clinically healthy patient. There would be a rapid attachment loss and bone loss which is taking place in that patient, unlike the chronic periodontitis. Chronic periodontitis is going to be a slow attachment loss, whereas aggressive periodontitis is going to be a rapid attachment loss. There is going to be family aggregation of the diseased individual, which means that if I ask the individual with aggressive periodontitis if his father or his sibling had a similar situation, he would reply it as yes. So these 3 characteristics, that is otherwise clinically healthy patient, rapid attachment loss and bone destruction, and family aggregation of the diseased individuals are the primary features of a person with aggressive periodontitis. Whereas there are secondary features which are common but not universal, that is amount of microbial deposits. It is inconsistent with disease severity. There is increased level of the bacteria Actinobacillus actinomyces. So this bacteria is more present in the aggressive periodontitis. So remember that the red complex microorganisms are present in the chronic periodontitis and the Actinobacillus actinomyces are present in the aggressive periodontitis. There is abnormalities in the phagocyte function. There is hyperresponsiveness of the macrophages. In some cases, it is a self-arresting disease progression. Aggressive periodontitis may be further classified into localized and generalized form. If it is a localized form, that will be a circumpubertal onset of disease, which means in and around the pubertal age, the disease would start. And there is a localized first molar or incisor involvement with proximal attachment loss and at least 2 permanent teeth, out of which one is a first molar. So remember that in a case of aggressive periodontitis, you would have either the molar or the incisor involvement present. Not all the teeth will be involved, like in the case of your localized, in case of your chronic periodontitis. So here, either the first molar or the incisal area will be involved. There will be a robust serum antibody response to the infecting agents. Generalized form, it's usually affecting people less than 30 years of age. There's a generalized proximal attachment loss affecting at least 3 teeth other than the first molars and the incisors. There's a pronounced episodic nature of periodontal destruction and poor serum antibody response to the infecting agents. Next, coming on to the common features. So as already told, it is less than 30 years of age and the patient is apparently healthy. This is characterized by rapid bone loss and attachment loss, absence of large amounts of plaque and calculus, unlike the chronic periodontitis, where chronic periodontitis has more amount of plaque and calculus. There's a family history of the condition being present. Next, coming on to the different forms, as I already told you, localized aggressive and generalized aggressive, we have already mentioned about what are the different forms, and this is in an elaborate manner. So other findings, A. competence is one of the main bacteria which is found there, and the others has been already discussed. Next, coming on to the clinical features of the localized aggressive periodontitis. So it is formerly known as the localized juvenile periodontitis. So juvenile, which means that it is of lesser aged people which gets it. And here the bone loss is faster than chronic periodontitis and mainly affects the first molar and the incisors. Clinical inflammation may not be obvious. Minimal plaque that rarely mineralizes. However, it contains elevated levels of the main bacteria, that is the AA comitans. Okay, other features could be that maxillary incisors migrate in the distal-labial direction. Increasing mobility of the affected teeth would be present. Periodontal abscess formation could be there, and sensitive root surfaces would be present. Rapid and severe loss of alveolar bone around more than one permanent teeth, usually the first molars and incisors, characterized by interproximal attachment loss of at least two permanent first teeth, that is your first molars and incisors, and it's frequently localized to the permanent molars and incisors. Okay, so you can see a condition here where the patient is fine. When you see such a condition, it means that it shows that the person is totally not having any condition, or he's not having any disease at all. Such beautiful gingiva it is. Then you can see the amount of bone loss which is occurring in the incisor area. In the lower photographs you can see. So the molar areas and the incisor areas, there is equal amount of bone loss which is occurring. So if you see the right and the left side of the molars, so if you see the lower molars, you could see that there's a correct mirror image. Like if it is there on the left side, how much amount of bone loss is there, the same amount of bone loss you can see on the right side as well. So this was one of the characteristic features of localized aggressive periodontitis, that there is a mirror image of the bone loss. So this is A comitans, which is resulting in the, and you could ask me why it is more specific on molars and incisors alone. So it was found by certain studies that there were certain reasons which were attributed to it, that A comitans was the first permanent teeth to erupt, and therefore sorry, the bacteria A. comitans colonizes the first permanent teeth to erupt. So it evades the host. Following the initial attack, the host will respond. So then antibodies are produced, and therefore it doesn't go to the other teeth. So this is why the other teeth is not involved, only the molars are involved. Next, the A. comitans may lose its ability to produce leukotoxin, so it may arrest its disease process to the other teeth, and the antagonistic bacteria may colonize the site and prevent the A. comitans from going to the other teeth. The fourth point, the root surfaces of the patients with LAP are often denuded, and this allows the bacteria to penetrate deep into the root and colonize the site. Next, coming on to the radiographic evaluation. So as I told you, it will be a vertical bone loss and is usually bilateral. So you will have a arc-shaped defect starting from the second premolar to the mesial of the second molar region. So here you can see an arc-shaped defect which is present, having a vertical bone loss. So clinical features of a generalized aggressive periodontitis, there is limited information due to reclassification of conditions. It includes conditions formerly known as generalized juvenile rapidly progressive periodontitis, affects 30 years and lesser than people, and bone loss attachment loss is more than 3 teeth, out of which molars and incisors are also part of them. Episodic nature to disease with periods of inactivity may last for years. Present. Episodic nature of the disease produces two different tissue responses. One could be the destructive phase and a non-destructive phase. So same as a chronic periodontitis where there is an active phase and an inactive phase, same way you have a destructive phase wherein the tissues may appear severely inflamed, ulcerated or fiery red, bleeding will be present, suppuration and active bone loss will be present. There could be a non-destructive phase where the tissues are pink, there will be no inflammation and the pockets will be deep, but the tissues would be fine. So what determinants of or virulence factors of A. commitans causes the diseases. So A. commitans produces agents such as leukotoxin, endotoxin, bacteriocin, and it also tries to suppress the immune activities present. It produces collagenases and chemotactic inhibition factors, which results in extensive destruction of bone in such patients. So, leave alone the chronic and aggressive periodontitis, the two broader terms, which was present in the 1999 classification. But the present 2017 classification, which we are following, has only the following particular classification, where you don't have it as specifically as aggressive and chronic periodontitis. You just have the word periodontitis there. All right. So, based on that periodontitis, it has been classified further as stages and grades. So, stages based on the severity and the complexity of the management, it has been classified as stage 1, stage 2, stage 3, and stage 4. Stage 1 is initial periodontitis, stage 2 is moderate, stage 3 is severe periodontitis with potential for additional tooth loss, stage 4 is severe periodontitis with potential for loss of dentition. Second one is the extent and distribution, whether it is localized, generalized, or is a molar incisor involvement alone. Third one is based on the grades. How is the progression of the disease, and what is the treatment response which should be anticipated treatment response. So grade A, they are slow rate of progression. So these are people with bone loss, but they would be going at a very slow rate of progression. Grade B, they would have a moderate bone loss or moderate attachment loss taking place. But grade C individuals are people with a rapid rate of disease progression. All right. So next, coming on to the periodontitis classification based on the 2017 classification. So I would like you to follow this particular classification. So if you want to tell that a particular area is you tell it as to tell it to be a periodontitis or diagnose it to be a periodontitis, then there should be an interdental clinical attachment loss of which is detectable at more than 2 non-adjacent teeth. There should be a buccal or a oral clinical attachment loss of more than 3 mm with pocketing of more than 3 mm detectable of at least more than 2 teeth. So remember that if you want to tell a case as periodontitis, you should have an interdental attachment loss. So it is not a pocket, remember, it should be an interdental attachment loss which is present at least 2 teeth, or it could be a buccal attachment loss of more than 3 mm at least more than 2 teeth. So interdental attachment loss or buccal attachment loss. So what are the differences of the 2017 classification from the 1999 classification? So this classification is a successfully treated stable periodontitis patient is also included under periodontal health. So supposing if you have already treated a patient and he is having a stable periodontium right now, but he is actually a person who has got some amount of bone loss, but now he's having a very good stable periodontium, so we classify him under the periodontal health rather than periodontitis again. So the entities chronic and aggressive periodontitis have been removed and has been replaced with a single entity called periodontitis. And for each of this stage, localized less than 30% of the teeth involved and generalized is more than 30% of the teeth involved, there's a molar incisor pattern. So these three are the extent which is involved, and then there is staging and grading as well. So these are the differences from the 1999 classification. So now, how do you diagnose a case of periodontitis? So as I told already, so clinical attachment loss, if it is present at more than 2 teeth, or the buccal attachment loss is present at more than 2 teeth, then you consider that to be a case of periodontitis. Please exclude cases of these 5 categories. That is your gingival recession, which is because of traumatic origin. Like for example, you are having a gingival recession, which is because of toothbrush trauma, cervical abrasion. So in those cases, you are not going to tell them as periodontitis. If there is a dental caries extending to in the cervical area of the tooth, that is below the subgingival area, so we don't call them as periodontitis. So if there is a presence of clinical attachment loss on the distal aspect of the second molar associated with the malposition or the extraction of the third molar, that is the third picture here. So if it is present, we don't call that as a periodontitis. If there is an endodontic lesion draining to the marginal periodontium and that has resulted in pocketing or clinical attachment loss, So we don't call that also as periodontitis. If there is an occurrence of vertical root fracture, we don't call that also as periodontitis. So the only thing which we call as periodontitis is if there is really plaque and calculus present, and if there is an attachment loss present. And because of that, if there's an attachment loss, we call that to be a periodontitis case. Right? So these are the 3 steps to staging and grading. You can go through this. I will go through the next slides for your easy understanding. So staging, as I told you, there are 4 stages: stage 1, stage 2, stage 3 and stage 4. So stage 1, the staging is based on the severity and complexity of the condition. So severity, we measure this based on the interdental clinical attachment loss at the greatest site. So if it is 1 to 2 mm of clinical attachment loss, you categorize as stage 1, 3 to 4 mm stage 2, more than 5 mm as stage 3 or stage 4. So there's a doubt always between stage 3 and stage 4. But you have further other classification. The staging includes further other ways as well to include it. So coming on to the radiographic bone loss, supposing if there is a coronal third of bone loss taking place, then it is considered to be a stage 1 or a stage 2 periodontal staging. But then if it is going beyond it, that is at the middle third or the apical third of the root is involved, then it could be a stage 3 or a stage 4 periodontal condition. Tooth loss, if there is no tooth loss, then you classify them into stage 1 or stage 2. Stage 3, if there is less than or equal to 4 teeth loss. Stage 4, less than or more than or equal to 5 teeth loss due to periodontitis, then you tell it as a stage 4 condition. So take note that if there is a tooth loss only due to periodontitis, then we classify them as stage 3 or stage 4. Now, how to differentiate between stage 1, stage 2, stage 3 and stage 4, because stage 1 and stage 2 are similar and stage 3 and stage 4 are similar based on the severity, but based on the complexity it is little different. So stage 1, if there is a maximum probing depth of less than or equal to 4 mm, then it is considered to be a stage 1 category. Maximum probing depth of 5 mm, then it is considered to be a stage 2 category. Stage 3, if there is a probing depth of 6 mm, then it's considered to be a stage 3 category, along with vertical bone loss of 3 mm, furcation involvement of class 2, class 3 or moderate ridge defect. But when it comes to stage 4, you could see that the patient is completely, he needs some complex rehabilitation because his tooth all is mobile or it could be not present. So there is complete masticatory dysfunction, secondary occlusal trauma, severe ridge defect, bite collapse, only less than 20 remaining teeth present. And so such a condition is called as stage 4. So this is something similar to your stage 4 of the cancer. That is totally the patient has nothing in his either all the teeth are mobile or the teeth is almost into partial completely edentulous. Coming on to the extent and distribution, it could be either localized if less than 30 teeth are involved, generalized if more than 30 teeth are involved, or if there is a molar or incisor involvement, we tell it as a molar incisor pattern. Next, coming on to the grading, so it has been graded as slow rate of progression, disease progression, moderate rate of disease progression and rapid rates of disease progression. So this has been based on the primary criteria, grade modifiers, risk of systemic impact of periodontitis and the biomarkers. So first, coming on to the primary criteria, so you have direct evidence of progression, that is with the help of the radiographs, indirect evidence of progression with the help of bone loss by age or the case phenotype. So direct evidence of progression, so supposing if an individual is having radiographs for the past 5 years, and if you see that there has been no loss of bone much for the past 5 years, then he's graded under grade A. If he has less than 2 mm of bone loss over the past 5 years with the help of the radiographs which you assess, then he's said to be a moderate a person with a moderate rate of disease progression. If it is more than 2 mm, it is called as rapid rate of disease progression. Next, coming on to the indirect evidence, that is we don't have a radiograph, so you calculate based on the present age how much is the bone loss present. So if it is so this is a ratio, that is percentage of bone loss by age. So if the person is having less than 0.25, then he is considered to be a slow rate of disease progression person. If it is 0.5 to 1 mm, 1, then it is a moderate rate of disease progression person. And if it's less than more than 1, then it is a rapid rate of disease progression person. So you are not able to find with this also, you have another category called as a case phenotype. So that is based on how much local factors he is having. So supposing if the person has high amount of local factors but he has very low levels of destruction, then he is said to be a slow rate of disease progression person. But then if the destruction as well as the amount of deposits which are present in the mouth is going to be equal, then he is a moderate rate of disease progression person. But if the destruction is more than the biofilm which is present, or if it is very rapid rate of disease progression, then you classify him to be him a rapid rate of disease progression person. Hope you're understanding this. Next, coming on to the grade modifiers. So risk factors such as smoking and diabetes could modify the disease progression rate. So smoking people, if they are non-smokers, they are people with very slow rate of disease progression. If they smoke less than 10 cigarettes, then they are into moderate category. More than 10 cigarettes, they are into rapid rate of disease progression. Diabetes, if they are normoglycemic with no diagnosis of their diabetes, if they are into slow. Moderate rate of progression if they have less than 7 HbA1c, and more than 7 HbA1c are into rapid rate of progression. Next, coming on to the CRP factors. So just generally we don't consider it at a clinical scenario level. So only the primary criteria and the grade modifiers we do consider. Next, coming on to the British Society of Periodontology, how do they stage and grade? So initially when a patient comes to you, you assess them, you check for the clinical attachment level, then you assess them with the radiographs, and then you find that he is a periodontitis patient, then you start staging and grading him. So once you start staging him, see the worst side possible, and then stage him into stage 1 if there is 15% of bone loss alone, stage 2 if there is a coronal third of the bone loss involved in the radiograph, stage 3 if the mid-root level is also involved, stage 4 if the apical third level is also involved, and grade them as based on the bone loss of the bone loss percentage by age as A, B and C, that is slow, moderate and rapid rate of progressions. So the key steps in coming on to the diagnosis would be to determine the type of the periodontal disease, whether it is periodontitis or the other forms. You have already learnt it in the classification. So leave alone the other forms. For this particular chapter, take the consideration of periodontitis. Once you have told it as periodontitis, see whether it is generalized, localized or an incisor molar pattern. Generalized, more than 30 teeth involved; localized, less than 30 teeth involved; incisor molar pattern, only if the incisors and the molars are involved. Right. Next, you are going to stage them. Stage 1, stage 2, stage 3 and stage 4. You have the different criteria. So based on that, put the patient as stage 1 or stage 2 or stage 3 or stage 4. And next comes your grading as A, B or C. So if you are going to tell a person as periodontitis, so you would have all these 4 conditions. So you would be telling periodontitis, which is generalized, could be a stage 3 grade B person. So you're going to classify periodontitis with all these factors. Okay. So coming on to the treatment plan. So the first and foremost would always be your non-surgical therapy. So which includes your mechanical and chemical plaque control, such as scaling and root planing, smoking cessation, antimicrobial therapy, mechanical SRP along with local drug delivery, and if possible, host modulation therapy. If this is not possible, then you go to the surgical periodontal therapy, which includes a wide range of surgical therapies, which we would be dealing it in different classes, individual classes for you in later years of your study. And last comes your maintenance therapy. Maintenance therapy is considered to be heart of your periodontal therapy. So you go it in a considered to be a sequence while you're doing your therapy. So for aggressive periodontitis, it is specifically going to be the antibiotic systemic tetracycline, which has to be given in conjunction with your surgical therapy. So because this has a part to fight against your A. comitans, the bacteria which is very much specific for aggressive periodontitis. So systemic antibiotics, that is tetracycline, has to be prescribed 1 hour before the surgery if you are going to carry on surgery in such individuals, and chlorhexidine rinses also should be prescribed. So this is about your the treatment plan which is involved for a periodontitis patient. But then we will go on with individual surgical, non-surgical as well as surgical phases in later parts of your lecture series as well as clinical when you come to the clinics. So if you have any doubt in this class, I know there's going to be a lot of doubts. So if you have any doubts in this class, please do approach us to get your doubts clear. Thank you.